Okay, brilliant. Thanks, everybody. As Anna said, I'm just going to share with you all a very long 8-year study that I did exploring how nursing staff and AAC users feel about AAC training. And from that, I developed a nursing staff training intervention based on their views. It was a mixed methods research and it was a feasibility study to kind of have a look at the feasibility and acceptability of the training and the impact on the knowledge and confidence of nursing staff here at the hospital. So I'll tell you a little bit about us and who we are. So today I'm going to talk about kind of what's the problem, why I decided to do this research. Then I'm going to go over, there's two phases to the research. There's phase one, and we're going to look at the methods and results. And from phase one, I developed the intervention. And then we're going to look at phase two, where I tested the intervention and have a look at the kind of implications of that. And I'll try and break it up a little bit with some videos as well. So I'm not sure about sort of the background to everybody. It would be really good if people have a moment just to pop in the chat and maybe what your background is, what your role is, because it could be a kind of huge range of different people, and it'd be quite good to get an idea if people are able to. But essentially, who I am, as we said, I'm a speech therapist, and I work in. We're very lucky in the rural hospital. We've got as assistive technology service there. And my area of experts, kind of, I guess, interest in particular is AAC, which is augmentative and alternative communication. And that's basically any kind of tools and strategies that people use who've got communication difficulties to communicate. As you can see here, we've got one of our AAC users who's using a head mouse to communicate. And in this research, I'm talking about aided communication, and I'm also focusing on high-tech communication because that's what the AAC users wanted to explore and wanted to train the nurses in. Let's go to the next one. Oh, seems to have. There we go. So, what's the problem? Why am I interested in this? Why does it matter? So, individuals with communication difficulties are incredibly vulnerable, especially when they are in hospitals and care home settings. We know that individuals with communication difficulties are 3 times more likely to experience adverse events when they're in hospitals, such as medication errors and clinical management issues. And communication difficulties are linked to a decline in care quality and decreased patient satisfaction, increased rates of safety incidents, readmissions, and extended hospital stays. There's also a wealth of evidence around patient experiences, patients with communication difficulties reporting how difficult they find it to use communication devices when they're in hospitals and care homes. And then we've also got lots of evidence that suggests that nurses indeed find it very challenging to work with AAC. They have difficulty understanding how it works or being able to use it and having the time to be able to use it and understand it. So there was just this general lack of evidence base for AAC training. So what we were currently doing in the hospital was kind of a mishmash of training, really. So if we can do a face-to-face handover, that's what we try and do. We do guidelines, but often they're quite difficult to read and they don't always get read. We did videos, but they're not always able to be accessible. And the nurses and the AAC users in our hospital reporting difficulties. We also do a lot of labelling, coloured labels, like to indicate charges and things, which we do find works. But essentially, what we know is that strategies that clinicians recommend but have not been evaluated or validated risk expenditure on resources that may or may not provide a material benefit to patient care, safety, or satisfaction. So, in a nutshell, we could be essentially throwing ourselves at strategies that may or may not work. And I wanted to really kind of work out what could work more effectively. So that led me to my kind of phase one objectives. And I wanted to establish, first of all, what kind of AAC areas they were finding most difficult. So establishing how the AAC users and the nursing staff felt about their communication, establish how the nursing staff and the AAC users felt about the current training they were receiving, and then develop a nurse staff training intervention based on a synthesis of their views and the literature. And for all of this, I use the background of the NIHR Complex Intervention Framework, which is like a framework you can use when you're developing any kind of complex interventions, and I followed that up to the feasibility level. So I didn't do a full-blown evaluation. I did a feasibility to evaluate whether it would be feasible to use this intervention. So I started off with a literature review, and in a nutshell, I didn't find much. There were only 13 studies. 10 were the people in the study were students or qualified nurses. No studies with healthcare assistants, and they were mostly acute hospitals, intensive care units, and one nursing home. No studies sought AAC users or people with communication difficulties to develop or deliver the training. Most were classroom-based or online, generic training, and 3 of the studies which analysed changes to quantitative conversational measures. So when they had one-to-one training, they had the most positive impacts. So I didn't have a lot to go on. So in phase 1, with how I essentially found out their views. With the AAC users, I did interviews, I emailed with them, and I did something called talking mats, which we'll mention in a minute. And I analysed that data with reflexive thematic analysis and descriptive statistics. And with the nursing staff, I did focus groups using talking mats, and I analysed the data with reflexive thematic analysis and descriptive statistics. It's quite controversial to use statistics with talking mats, but I essentially I'm in a talking mats research group and kind of established how I could use it. And I added, you'll see in a minute, I added some kind of numbers to the top scale. So I was able to get some kind of a score that I could use to compare the nurses and the AAC users' views. And reflexive thematic analysis was used because essentially my role, knowing these patients, knowing these nurses, was very central to it all. And I needed a method of analysis where I could really explore how my views could be impacting on the data and to kind of ensure that I could be as reflective on the process as possible. So this is a talking mat, and talking mats are a framework that we can use. It was developed for people with communication difficulties, but actually is used more and more in research and generally with people with and without communication difficulties. And it's a great way of finding out how people are feeling about a topic. As you can see here, you've got a top scale, positive and negative. So here I was finding out from the AAC users how they felt about the current training that we did with them. So we've got positive and negative, so what helped on the left and didn't help on the right. Then I had a series of options, so things like, do the photo guidelines help? Does training and nurse handover help? Does practicing help? And then I've got a topic at the bottom to be discussed, which was the current training. So in phase 1, I had 3 AAC users. 2 had experienced a brainstem stroke and 1 had traumatic brain injury. They were all eye gaze users and they all used partner scanning with a letter chart, and they were from our long-term care and ventilation wards. And the nursing staff, I had 4 focus groups of 3 to 4 staff. There were 12 staff, 3 nurses and 9 healthcare assistants from long-term care, rehab and ventilation wards. So this is just an illustration really of one of the mats I did. So all of the nurses in the group, in the focus groups, had some little symbols and they could throw them down on the board according to where they felt their views were. And I found it worked really well. They were interacting really well with each other. As you can see here, this was the question about their ideal training. So what they thought would be really useful in AAC training, useful and less useful. And so they could each put down their views, which I then analysed and all put together to compare it to the AAC user views. I thought it might be helpful to have a look at some comments. So these are just some comments from the nursing staff about their views on AAC and training. Just to give you a few seconds to have a look. So I had lots of kind of rich data like this, which the nurses said while they were doing the talking mats, so I could record. And just some comments from the AAC users. So as you can see, I was really sort of learning about the challenges and the areas they were having difficulty. So once I had the AAC user information and I had the nursing information and all of their views, I had to put it together. So when you're using any kind of mixed methods research, you need to have a way of working out how to, a strategy is basically required to merge the results. And I use something called triangulation, and it's a methodological approach to try to kind of look at where the data is converging and where it's kind of coming together and compare the findings. So I used a process called triangulation, which was by Farmer et al. In 2006. And I used it in this research. And it really kind of helps you to identify kind of themes and the prominence and examples within those themes, where you can agree, you can assign agreement, partial agreement, silence, or dissonance where they disagree. So as you can see, this is just kind of a working example. Apologies for the photo. There seems to be a dog mat underneath my mat there. It's all very scrappy, but I promise you there was a purpose to it. And I was using it to find out how the nursing staff and the AAC users felt about the current training, and then how the nursing staff and the AAC users felt about their ideal training. So let's have a look. So I had a look at all of the prominence and the examples within each area. So you can see here the themes that had complete agreement only were that they all felt that the picture guidelines had a very much a mixed impact. Some of them felt they did work, a lot of them felt there were issues with them, if they were out of date, patients' positions were changing. They all very much felt that practical elements are useful and training and nurse handover can be useful. And then kind of less so practicing with a therapist and practicing with AAC user and various others. So the strongest areas really we felt were the kind of the practical elements coming through. And that's the current training though. That was what we were doing. But I then focused on what they thought their ideal training would be. And here they said practical and technical training, practicing with an AAC user based on the ward. They all agreed that simulated patients and simulated devices were not effective. They wanted patients face to face, getting feedback from an AAC user in their performance and having the AAC user as a trainer. So these were just kind of the kind of themes. However, I needed to consider that amongst the literature in this area, there's a lot of literature around intervention and behaviour change. And I needed to explore that literature to make sure that I was being clear about what kind of training I was developing. And so it was recommended by my supervisors in my research that I consider that literature. So I did another mini literature review to have a look at behaviour change and intervention literature. And I found 12 papers. And the key findings really were that when you're doing any kind of training, when you're looking at content, you need to be clear about what strategy, and strategy instructions are quite popular, particularly in the AAC world. So teaching things like give the person time, ask them a question, check the device is working, check the position, be very specific, be patient-centered and relevant to practice. Then methods of delivery, the literature said, use lots of practice and reflection, train the trainer can be popular and very successful, consider role play, workplace-based and online resources, and then evaluation, feedback to the trainee and performance checklists. So I took that literature, added it to the data that I'd got from the AAC users and the nurses, and came up with a second lot of triangulation. So from here, I asked the questions, what does the research data and the literature say about the content of AAC training, the delivery methods, and evaluation? So I was putting all of this together to try and see how we could develop training. And this is what we came up with. So the AAC training literature, behaviour change, intervention literature, and the participant data. This was their views on content, patient-focused, individualised training, practical content, information about AAC and information about communication needs and strategies. We really found that in particular the nurses wanted to know, why has this person got AAC and what is AAC? Then, again, from combining everything, views on delivery methods, learning through interactive practical sessions, Systematic processes, so kind of making it very clear, this is what we're going to do, having checklists, following through strategy instruction. Having management and peer support behind it, so making sure that having your nurse colleagues supporting you. AAC user involvement in training and having feedback on performance. Train the trainer, ward-based, support from web-based resources and use of videos. And finally, this is what everything said about the views on evaluating the training. How do we evaluate the training? And everything pointed to kind of two things really. Constructive feedback, so having feedback on the tasks that you've done in the training, and a performance checklist. So having so the person puts the eye gaze onto the mount, fixes it in place properly. The person checks that the person can communicate. So going through. So those are some of the, essentially what I got from phase one, the key themes that emerged. So main areas I got were the challenges of complex communication needs in AAC, essentially incredibly challenging, and the nurses were dealing with a lot of technology that they had to establish and work out how to use. We also discovered when we were looking at the communication side that linguistic challenges can be difficult. So especially when the nurses have to spell something out, and English is a second language for them, and the device requires them to spell. So like using the charts can often be very tricky. But the key was person-centered training, learning about train the trainer if possible, practical, personalised and functional with clear processes and procedures, AAC user involvement, ward-based and accessible. And so I then had to work out how to kind of put this all together. So as I said, I used the NIHR and Medical Research Council framework for developing interventions. And then I also identified a model by Gagné, who in 1985 and 2015, he had an instructional design model, which kind of helps when you're delivering any kind of healthcare interventions. And I used that to help guide and give me the framework for developing some training on high-tech AAC. Okay, so this is what I came up with. So you can see here how the green elements are based on phase one, and we've got pink, which is Gagné's theory. So it's kind of color coded, but in a nutshell, this was the procedure I followed with each of my training sessions. So, and it's all based on everything that I found in phase one. So with each training session that I did, which I'll go over in a minute, we gained the nursing staff's attention with an all about me video, and we'll watch one in a minute. So it was all about what the AAC user wants the nurses to know about them and how they communicate, why they can't speak, what's AAC, and what do the nurses need to know about it. And as we said in the research, that was really something that was key. Then we introduced an AAC user checklist. We made some competencies for training that the nurses needed to have a look at and to follow. And it was expected that upon completing this training, you will be able to do X, Y, Z, so set up the device, etc. Then simulate recall of prior learning. Has anyone ever seen any issues with it? Anyone ever seen any AAC before? You know, what happened when you used it? What do you feel about AAC? Then number 4, we presented the stimulus. So I introduce the AAC, state the competencies and the guidelines. Then number 5, provide learning guidance. So they would observe me setting up and using the AAC with the user and explain each step. Then I would get the learners or the nursing staff to have a go at setting it up themselves and maybe give them an activity to do, you know, have a chat with the person about what they're doing tomorrow or what they did at the weekend. Then number 7, provide feedback. So I would give them feedback and they would reflect. Then the AAC user would give them feedback on their skills. And then when the nurses are training each other, the other nurses would give each other feedback as well. And then the idea is going forward, we would then assess the performance with the competencies. So we would go through the checklist, and I'll show you one in a minute. And then to enhance, number 9, enhance retention and transfer, the nurses would then go on to try and use this and use the competencies to train other nurses. To give you an example, I'm going to share a video of one of the videos that we used in the training. So 1 second while I get it up.
Taking computer out from me, ask me first. For the best place of the computer is the green face at the middle of the box.
Hi Riti, good morning. I'm going to be attaching your eye gaze now so you can communicate with us. Almost there. Is that okay? Is it aligned? Yeah. Type something for me. Okay, that's great. So it's working then. Thanks. Hi Riti, as we're going to assist you back to bed now, I'm just going to remove your eye gaze device and then I'm going to connect it to the standing frame. Okay? There you go, it's clipped in and it's safe. So I'm going to move it out of the way here. And once you're in bed, we can place it in front of you.
While transferring the device from bed to chair, hold the device on either side so the holder at top. Please don't touch the wires at back or screen inside. Not just focus on the green face, the screen should be in the middle of bed parallel to my eyes. Otherwise it hurts my eyes. If you see me blink the eyes to computer means look at the computer. Thank you for watching.
Okay, so that was a video. That was one of the training example of one of the training videos that we did. And then I mentioned quite a bit about the competencies, and this is just an example. And please bear in mind, these are very, very draft. So just an example of and obviously I've just blanked out the patient's name, but these are the example of kind of the competencies. So we developed them on the guidelines that we use in the hospital, but with these, they were developed so that the nurses could train each other. So they would be things like, number one, introduce the task. The nurse introduces themselves, states the task ahead, and gets consent to set up the eye gaze. Hello, my name is so-and-so. We're going to set up your eye gaze. Is that okay with you? and making sure the person said yes and given their consent. And then things like safety, putting the mounting arm onto the wheelchair, so putting the eye gaze into the wheelchair safely. Have the nurse slide the mounting arm into the bracket on the right side of the wheelchair and locking it with the blue knob. And understanding that this must be locked or it could fall out. And understanding that it needs to be removed when travelling in a motor vehicle or there's a risk of injury or death in an accident. So it's just going through all of the stages. But it was also personalised, because you'll see on the right that this person, this AAC user, really likes the nurses to check with him. He's quite technical. So one of the main things that all of the nurses wanted was a troubleshooting section at the end. But this person's quite technical, so it was please let him try to fix it if there's a problem and ask him what he wants you to do. But if he can't answer or he doesn't know, does the nurse know what to do if the computer doesn't turn on? The nurse needs to know to check if it's charged. The nurse needs to know how to do a restart, etc. So I had like troubleshooting sections as well. So that's in a nutshell where the intervention's coming from. But I then needed to see if any of it would work. So phase 2 of my study was evaluating the impact of the training intervention. So all of those little stages that I went over earlier, it was testing those on the nurse's knowledge and confidence in using AAC, and then determining the feasibility and the acceptability of the training on with the nursing staff. So how I did this, so again, I interviewed the AAC users and I used talking mats, and I analysed the data again with reflexive thematic analysis and some statistics. And with the nurses, I did the training, but I did surveys pre and post training. I did a paper questionnaire and I analysed it with descriptive statistics and qualitative content analysis, which is a great way of exploring whether there's any kind of real kind of categories and themes coming out, but also counting the numbers of those. So you can see pre and post whether their knowledge, they've provided any extra kind of knowledge pre and post the training. I did paper surveys because I kind of felt that it was going to be very difficult for all of the nurses to be able to get onto computers to answer the questions, and actually it worked really well. So phase 2 participants, I had 3 AAC users. One was the same, but sadly the other 2 had died. So I had 2 new AAC users and 2 were ventilated. One was a stroke, another had a neurological infection, and they were from the ventilation wards and long-term care ward. And I had 30 nursing staff, which was 11 nurses, 18 healthcare assistants, 1 nursing associate and 1 trainee nursing associate. And I tested the intervention between June and July 2024. I had 11 sessions, and the numbers of nursing staff varied between 2 to 6 on each ward, and the times of the day varied, so I was very flexible. It was when the most of the nursing staff were free and when they could be available. So I'm just going to share with you now another video of me doing a talking mat to kind of explain how I got the data that I did from the AAC users. So, okay, Richard. So the second question is all about the methods that we used. So as you remember, way back a few years ago, we asked yourself and the nurses, what methods should we test? And we used those methods and tried them out a bit. So methods of training and helping learning. What did you think was very effective, effective and not effective? So if we start off with the video. So how effective did you feel the video was? Very effective, effective, not effective. So you have a look. Very effective, effective. Yeah, okay. The next one is having a competency checklist. Did you feel that was very effective? Yeah. Okay. The therapist doing a demonstration. Do you feel that's very effective? Effective? Okay. The nurse or the HCA having a practice with the device. Do you feel that's very effective? Effective? Okay. The nurses watching their colleagues trying it out, them putting the device on. Very effective? Okay. The nurses, HCAs giving feedback to each other. while they're doing it. Very effective. The therapist giving feedback to the nurses. Very effective. Effective. Okay. And Richard, you giving feedback to them as we're doing it. Very effective. Effective. Okay. Okay, so just to go over, we're talking about the methods that we tested out a little bit in the training. So very effective, you got the competencies, the nurses watching the other nurses doing it, and them giving each other feedback was very effective. Effective was the video, the therapist demo, nurse and HCA practicing, therapist giving feedback, and you giving feedback. But there wasn't anything that we did that you thought was not effective. Is that correct? Okay. Do you want to move anything? Okay. Anything you wanted to add? Okay, thank you. Okay, so that was just an example just to show you all how, one of the examples of one of the interviews I did with the AAC users. And then he also gave me extra information through email and also using his chart and his eye gaze. So we used lots of different methods. Okay, so here's just some of the results, just some of the quotes from nursing staff that they wrote down in their survey, which you can just have a little look at. So these are examples of nurses' views from the survey. Okay, just because of time, I'm just going to whiz through. Oh, here's an example of, one of the talking mats from one of the AAC users. So this is the view, a view of the training. So that's so that you can get a better view of it. And some more views of the nursing staff. And also some of the AAC users. Okay, so to put all this together, I had to bring out that old friend triangulation again, and I had to think about, okay, putting all of the results I had from what the AAC users said about the training and the nurses said about the training. So what was the impact of this training intervention on the nurses' knowledge, skills and confidence? And also how feasible and acceptable were the methods used in the training? And how feasible and acceptable were some of the elements of the training to the AAC users and the nursing staff? So let's have a look. So the impact of the intervention on the nursing staff's knowledge and skills, according to the AAC users and the nursing staff, were the following. What we found were there was increased knowledge and skills of safe AAC device setup, and that was really interesting. So often when we were looking at setting up the eye gaze onto the wheelchair mounts, both the AAC users and the nursing staff demonstrated a lot more knowledge about fixing it in place, making sure it was safe, making sure it was in the right position. They also demonstrated increased knowledge and skills in interacting with AAC users. So being aware of giving people time, checking things were working, making sure that they hadn't misunderstood each other. There was also awareness and knowledge of the AAC users' skills. So the nurses seemed to demonstrate more awareness of what the AAC users could do and their abilities. Also increased knowledge about AAC and knowledge of each other's knowledge and skills, so learning from each other. Then we had a look at effectiveness of the methods used in the training. So it's complete, so full agreement and also some kind of partial agreement across the data sets. So what they all felt, AAC users and nurses, were that nurses learning from each other, getting feedback from the AAC user and practicing themselves were all very effective. Less effective, but still effective, were getting feedback from myself, demonstrations, the competency checklist, and the training video. Oh, where was my evaluation? Oh, sorry. Let's go that way. Evaluation, yep, sorry. Looking at the final bit was just the elements, some of the elements. The contents of they felt that the information provided in the training was acceptable, practical elements were acceptable, the length of time, so it took about 20 minutes each one. Based on the ward, they felt the location was acceptable and they felt that surveys were acceptable. So I finally put together all of the key findings from everything that I took. And these are kind of some of my, I guess, takeaway messages from it. We found that the nursing staff's knowledge and confidence in interacting with AAC users was better post-intervention, and the nursing staff demonstrated increased knowledge of how to interact with an AAC user, the role of an AAC device, and knowledge about individual AAC device and setup and use. So bear in mind this training was very much focused on the individual AAC user and their own device. Practical, hands-on learning seemed to really help them to learn. And also involving the AAC user and the nursing staff in the training. So watching their colleagues on the videos, getting feedback from each other, learning and getting feedback from the AAC user. They all fed back that strategy instruction and checklists were very, very helpful. And that was something definitely that came through. They found them easier to follow and to use than the guidelines that we used to use. And they felt that the length and the evaluation tools were acceptable. However, no research was without its limitations, and mine certainly wasn't. The main limitation to this research study essentially was me, because although my familiarity with the wards and the staff and the patients was very beneficial because I knew how their AAC worked. If it broke in an interview, I could fix it generally, and I knew them and I understood their non-verbal communication. There's also the element of being of reflecting, and I needed to reflect the whole time because they could have responded in specific ways because they were aware of me and they knew me and they maybe wanted to please me in different ways in response. So I had to be very neutral in all of my questioning and consider how I was reacting to responses. I'm aware that the transferability of this research could potentially be limited by the small numbers and the very unique characteristics of the participants. However, I think that certain elements of it would definitely be transferable, and some of the research that I found would be very useful. I'm aware there was a lack of diversity in the communication challenges of the AAC users. I didn't have anyone with aphasia, I didn't have anyone with cognitive impairments. The study was very technical focused. It was also very focused on high tech and not low tech AAC. But again, I think it could be tested with low tech as well. I also only reported changes to behaviour and interaction. I didn't analyse actual behavioural changes. But to finish off, in a nutshell, this research has already had a massive impact, I feel, on my clinical practice, and being aware of the value of face-to-face handovers and not just sticking up a load of guidelines on a wall, because I know now that those are not going to work. I'm very much, I've only literally, as Anna said, only finished my PhD last week. So I've only just come fresh from it, but I'm definitely keen on looking at how we could introduce some AAC competencies into the hospital. And I'm really interested in looking at how we could involve more of the AAC users and the nursing staff in our training, delivery and development. And also thinking about the practical evaluation of the skills, maybe using the competencies, having checklists and looking at how we can make sure that those practical skills and the safety skills that we taught could be used. So, yeah, I'm just on 45 minutes, which is where I needed to be. So, yeah, I think that's me. So
Brilliant. Thank you so much, Helen. That was like a whistle-stop tour. So I'm sure if anyone has got any questions, do pop them into the chat. I've got a couple to get started with, so I'll get to those quickly first. Firstly, do all the training stages have to be delivered at once, or can you only deliver one or two?
yeah, so what I felt from it was that although Gagnier's model, you do have to follow those stages, I felt that items from it could be used. So things like we could do training just with the face-to-face and the checklists. I didn't find that the video, for example, turned out to be that effective. It took hours to make. It was quite a big, it would be too time consuming, I felt, to be practical in any hospital or care home. So I would probably remove that element and maybe just take the elements that I found that were effective and use those. So I think it could definitely be pared down.
Okay, thank you. And will you use videos in your training in the future?
Yeah, so again, that's really interesting. And the feedback that I got were that videos in the past had not been effective because they were difficult to access. And I think access to videos is a difficult one. And I think that we could explore things like using QR codes and things to scan to get videos up. But certainly from my research, they didn't. They were more work. They were just far too much work to get the effects. So I think there's something that we have to consider, but I'm not quite sure if we will. Yeah.
Okay, all right. We've got an anonymous question asking, how did you find making sure you trained all the staff with staffing changes and shift working, etc.?
Yes, so I wasn't able to train because it was a research project. I didn't have to train all of the staff, so I trained as many as I possibly could at different times of the day. So each ward had different requests for times, and I went in whenever I could. Like it could be kind of 5 or 6 o'clock, or it could be 2 o'clock. It was whenever. But because this was a research project, I didn't. But that's a really good question because going forward, I do want to be looking at training all the staff. At the moment, what's really good at the hospital is that Compass are involved in the clinical induction. So we do teach AAC device setup and technology setup and use in induction. So we do get all of the new staff, but I do need to now think how we get the current staff. That's very true.
Okay, all right. And the next question is from Sophie, and she asks, could your method of training be used with less disabled users?
Um, I guess, do you mean sort of like less, I mean, maybe like not high tech AAC, sorry, like sort of not eye gaze, because I guess eye gaze is quite complex. Do you think that's,
I think she's thinking about the person. Oh, Sophie says yes, yes, that's
yeah,
right.
yeah. Yeah,
Thanks, Sophie.
yeah, I think so. I like to think so because I was following all of the I was following the kind of theory of sort of strategy instruction, and I think that that seemed to be very effective. So I definitely think that it could be, although I didn't test it with, for example, low tech AAC, I think that it could be used with that because um, the impact and the strategies are kind of very, very similar, following a procedure and following and using it to interact. So I think that it could be, yes.
Okay, wonderful. Well, if anyone's got any more questions, do pop them in the chat or the Q&A tab for us quickly. Otherwise, I think we can wrap up this open lecture. Thank you very much. Right, Becca, sorry, has just got one question. Did you create the competencies originally, or is there a framework that you used?
Yeah, so I took our guidelines. We've spent years developing our guidelines in Compass. So I took those and then I followed the guidance. There's quite a lot of research out there in medicine, particularly about competency checklists. They use them a lot, like pre and post surgery, and they're quite popular. There's a lot of information about them. So I used that information and combined them with our guidelines to develop them. Um, yeah, so that's where it came from. So I'm hoping that I will have a template that we will use going forward in Compass.
Okay, wonderful. Well, Helen, thank you so much. And to our lovely audience, as always, thank you for joining us. If you think of a question or there was something that you think of later, do drop us an email and we'll come back to you. We'll email a copy of this recording round and it'll be available on YouTube. So if you've got any colleagues who missed it today, feel free to send that one to them. But Helen, thank you so much for sharing your research with us today and for delivering this open lecture. We really appreciate it. And for anyone interested in our events for next year, they're all now live on the website. So we've got a whole programme of open lectures that are free of charge and then some training courses and conferences. So hopefully you can join us on site at the RHN or online again. Thank you very much.
Thank you.